Let's begin. A 14-year-old girl is referred to the pediatric unit with reduced urine output and lethargy. She has been passing bloody diarrhea for the past 4 days. On admission, she appears dehydrated. Bloods show the following. Sodium is normal, potassium is normal, bicarbonate is on the lower end of normal, urea is high, creatinine is high, HB is low. I don't know what are the normal ranges for pediatrics. MCV is normal. Platelets, normal is 150 to 400, so this is low. White blood cells is high, I think. So given the likely diagnosis of hemolytic uremic syndrome, which one of the following organisms is the most likely cause? I think it's E. coli, type of E. coli, 0157. Hemolytic uremic syndrome classically caused by E. coli 0157H7. So what is hemolytic uremic syndrome? Hemolytic uremic syndrome is generally seen in young children and produces a triad of acute kidney injury, microangiopathic hemolytic anemia, thrombocytopenia. Most cases are secondary, termed typical HUS, classically Shiga toxin producing E. coli. Pneumococcal infection, HIV. Oh well. Next question. A 52-year-old man has an Achilles tendon rupture while playing tennis. He has no past medical history and has had no previous musculoskeletal problems. During the preceding week, he was commenced on antibiotic therapy for an infection and has been taking it for the past 7 days. Which antibiotic was he likely to have started? What antibiotics can predispose someone to Achilles tendon rupture? I don't know. I guess I have to take a guess and learn from my mistake then. Let me try and think. Benzyl penicillin should be quite a safe antibiotic, I think. Ciprofloxacin. Benzyl penicillin is used even in children, so nitrofurantoin is used in UTI, and I've never heard of this side effect. So between these three, Cipro. Doxycycline is used in acne. Clarithromycin is quite commonly used as well. Yeah, I'm just gonna guess Cipro. Oh, Cipro is the answer. Ciprofloxacin is the likely causative medication with new onset Achilles tendon disorders. Tendinitis and tendon rupture is a key effect of which to be aware. Okay, ciprofloxacin is a likely causative medication with new onset Achilles tendon disorders. Tendinitis and tendon rupture are key side effects of which to be aware. Is it caused by any other drug? Achilles tendon rupture, Simon's triad, ultrasound, acute referral. Is it just ciprofloxacin that causes it? Tendon disorders. How does ciprofloxacin work anyway? Ciprofloxacin mechanism. Where? Pharmacological properties, pharmacodynamic properties. It's a fluoroquinolone. The bacterial action of ciprofloxacin results from the inhibition of both type 2 topoisomerase and topoisomerase 4, required for bacterial DNA replication. It doesn't give any clue about how it can cause tendinitis. Guess just have to memorize ciprofloxacin as something that might cause tendinitis. Next question. A 33-year-old male presents to the ENT having been referred by his GP. He perforated his tympanic membrane 6 months ago and it has failed to heal spontaneously over this time. What is the most appropriate next step in management? Referred by his GP, perforated tympanic membrane 6 months ago, failed to heal. How do we heal it? Laryngoplasty? It's an adult. Steroid eardrops probably wouldn't help. Advised to keep the ear dry and healing should occur within 6 to 8 weeks. No, this is the initial management, but in the past 6 months it hasn't healed yet, so we need to do something about it. Stapedectomy, removing the bone, probably not. Vent insertion, no. So we just patch it up, laryngoplasty. If a perforated tympanic membrane does not heal by itself, a laryngoplasty may be performed. The correct answer is laryngoplasty, which is an operation performed to repair the perforation. This is appropriate as spontaneous healing has failed to occur. Following a perforation, healing should occur within 6 to 8 weeks. However, in this situation, it has failed to occur after 6 months. Making waiting another 6 to 8 weeks is inappropriate. Okay. Next question. A 26-year-old male presents with nausea, malaise, and jaundice. He returned 3 weeks ago from a holiday to India. On examination, he has a moderate hepatosplenomegaly and yellowing of the sclera. He also has dark urine and pale stools. What is the most likely diagnosis? So what's going on here? He returned from India, probably trying to indicate something infective. Hepatosplenomegaly, both liver and spleen is enlarged, and there's jaundice. Dark urine and pale stools is a cholestatic jaundice, right? Yeah, the bowel is not getting into the intestines, so that's what makes the pale stool. Dark urine is conjugated bilirubin in the bloodstream. So it's an obstructive jaundice picture. What causes obstructive jaundice? Wait, it's not even obstructive jaundice. It's Hep A to Hep E. Okay, which one is fecal oral route? He went to India. It didn't. Probably something he ate has caused his hepatitis. No mention about any sexual activity. So either hepatitis A or hepatitis E, both of these are fecal oral route. Which one could it be? If I'm not mistaken, hepatitis E is mostly associated with eating undercooked pork. You're gonna guess Hep A. Yes. Hepatitis A is an RNA virus that is spread by the fecal oral routes. It is very common and particularly associated with travelers. Treatment is supportive because the condition is usually self-limiting. Hepatitis A infection has a short incubation period of 15 to 50 days, which would also fit this scenario. Hep E is also spread by fecal oral route and should be suspected if the disease is more severe in pregnant women or if hepatitis A has been excluded. So you need to exclude Hep A first because probably it's more common in this patient. This is a less likely answer as Hep A infection is much more common. Yeah. Transmission of Hep B and C virus results from exposure to infectious blood or body fluids containing blood. Possible forms of transmission include sexual contact, blood transfusions, and transfusions with other human blood products, reuse of contaminated needles and syringes, and vertical transmission from mother to child during childbirth. There are no risk factors for Hep B or Hep C infection stated in this question. Hep D virus is considered to be subviral satellite because it can propagate only in the presence of Hep B. Okay, next question. At what age would the average child acquire the ability to crawl? On average, 18 months is walking, so crawling between these three. I would say 9 months. Is it 9 months? Let's try 9 months. Yes, 9 months is the answer. Developmental milestones, gross motor. 9 months, pulls to standing and crawls. 18 months, 8. Walking is 13 to 15 months, not 18 months. Okay. Sit without support is 8 months. I already forgotten the developmental milestones. I remember there was a video about it. Developmental history. Let's do this.
And today we'll be looking at how to be assessed in child, namely gross motor, vision and fine motor, speech and hearing, and social. So these are the 4 areas. I remember this using the acronym GFSS, reference super sexy. You can remember it however you like, but this is how I do it. 4 milestones for gross motor, and I also remember the limit ages. So limit ages are actually the ages whereby most of the children at this age should already achieve this milestone. So about 95%, which is 2 standard deviations above the mean, should already have head control by the age of 4 months, for example. So if they haven't reached the age of 4 months, they haven't had head control by the age of 4 months, then we should investigate further. So these are the ages to remember, the limit ages, right? So the milestones are head control, sitting unsupported, stand with support, and walk independently. You can remember by chronological order, right? So first you can control the head, then you sit, then stand, then you walk. And the numbers to remember are 4, 9, 12, and 18. So 4 months, 9 months, 12 months, and 18 months, right? And in older children, let's say the child is 3 or 4 years old or above, you can just ask about ability of the child. Can they run up and down the stairs? Yeah, this is one of the later milestones, right? So you ask depending on the child's age. So if the child is about 3 months, you're going to ask about head control, and you're not going to ask about everything else because it's just a waste of time. It's obvious that they haven't reached that yet. So let's say the child is about 9 months, so you're going to ask head control and sitting unsupported. And maybe you can go to stand with support because they might already reach it, but this is the limit age. But you're not going to ask walking independently or or running up and down the stairs. And likewise, if if the child is 6, 7 years old, you're not going to ask all this because it's obvious that they can already do this. unless there's some obvious developmental delay, then you're gonna ask. Right. Next is fine motor and vision. The 4 milestones that I remember are follow face, reach for objects, transfers objects from one hand to the other, and pincer grip. So the first part is the vision part, right? And then after they can see the object, they're going to reach for the object, and they can grab the object, common grasp that I don't include here. Then they can transfer object from one hand to the other, and then they can pincer grip, which is gripping using only the thumb and the index finger. So the numbers to remember are 3, 6, 9, 12. Easier to remember, right? Just now was 4, 9, 12, 18. Now it's 3, 6, 9, 12. Right? 3 months follow face, 6 months reach for objects, 9 months transfer, 12 months pincer grip. And again, these are usually for children below 1 year. 12 months is 1 year. So if the child is older than 1 year, there are other ways to assess this field of development. So in older children, you assess for drawing, and I'm going to show you how to remember the milestones for drawing. Let me get my pen here. Right. So for drawing milestones, so I like to draw. This was taught to me by my lecturer in my university. So I'm just sharing this with you guys. It's not created by me, but just sharing this knowledge. So I draw a stick man with an antenna, or rather a stick girl with an antenna. So it goes like this. So this is the filament of the antenna. This is a straight line in the head, body, and legs. So draw the hands, and you complete this shape. It's a square, and this is a triangle. And then let me label all this. So by 1.5 years, the child should be able to scribble like this. So this is 1.5 years, or 18 months. And then by 2 years, the child is supposed to be able to draw a straight line. And by 3 years, the child is supposed to be able to draw a circle. By 4 years, a square. And by 5 years, a triangle. Right? It's a very useful diagram to remember the drawing milestones, the fine motor milestones for older children. Okay. So next is speech and hearing. For speech and hearing, and also the social milestone, I remember 5 milestones. So for speech and hearing, the first one is polysyllabic babble. Second is consonant babble. So polysyllabic babble is things like mama, papa, 2 syllables. Consonant babble, consonants are anything other than vowels, so not A, E, I, O, U, but consonants are like M and N, like and these are consonant babbles. And then after that is 6 different words with meaning, 1 word at a time. So they can say 1 word at a time, but they know 6 different words that has meaning. And then after that, they manage to combine 2 words, and after that, 3-word sentence, right? So the numbers to remember are 7, 10, 18, 2, and 2.5. So this is a bit difficult to remember, but the way I remember is 7 plus 10, and then add 1 is 18, and then 2 and 2.5, right? And all of these are in months. 7 months, 10 months, 18 months, 2 years, 2.5 years, right? So I think that's good. Right. Lastly is the social milestones. Same as before, I remember 5 milestones. These are smiling, fear of strangers, feeding self with a spoon, symbolic play, and interactive play. Right. Smiling, they can reach this by a very young age. So by 8 weeks, they already can smile. And fear of strangers, they might show that they are uncomfortable, or they might cry around strangers. Feeding self with a spoon, that's self-explanatory. Symbolic play. So symbolic play is some sort like they can play with dolls, and the dolls have a character. So the dolls symbolize a person. Or they play cooking, or in Malay they call it main masak-masak. So they can imagine that they are somebody who they are the housewife, and they are cooking for the children and things like that, playing house. Or if it's a guy playing with cars or planes, these are symbolic plays. Okay, and then after that comes interactive play, so they are playing with other children, right? And the ages to remember, the numbers to remember are 8, 10, 18, 2 to 2.5, and 3 to 3.5, right? So the way I remember this is 8 plus 10 is 18, then 2 to 2.5, 3 to 3.5. And one thing to take note is that 8 is in weeks. You can remember it quite easily because you know that for smiling, it comes really early in life. So 8 weeks, smile, 10 months, fear of strangers, 18 months, feeding self with a spoon, 2 to 2.5 years, symbolic play, 3 to 3.5 years, interactive play.
Okay. So gross motor head control 4, 9, 12, 18. 3, 6, 9, 12. 7, 10, 18, 2, 2.5. 8, 10, 18, 2 to 2.5. 3 to 3.5. Okay, back to my questions. Next question. A 23-year-old student is brought into the emergency department by paramedics. He is unconscious. Bilirubin is high, I think. What's the normal value? Bilirubin normal is 3 to 17, so this is very high. ALP is high, ALT is super high. AST is super high as well. Albumin is 27, which is low. Albumin. Albumin. Total protein. They don't have an albumin value today. No, it's not stated here. Please interpret his liver function tests and select the most appropriate investigation which would confirm the most likely diagnosis. He 23-year-old student, unconscious. What's causing such high liver functions? Paracetamol? Most likely diagnosis. What can be causing such high AST and ALT? This indicates hepatocyte damage more than anything else. Hep A causes hepatocyte damage. Hep B also causes hepatocyte damage. Abdominal ultrasound, not sure what you're gonna see there. Unconscious. Are you suspecting liver rupture? I don't think so. Doesn't say anything about a history of trauma. But alcohols wouldn't cause such high hepatocytes, I think. Could be a paracetamol overdose given the age. High risk of suicide. Yeah. So the answer is paracetamol level. A transaminitis, elevated ALT and AST in the 10,000s is most commonly caused by paracetamol overdose. Other important points, Hep A and Hep B would both usually cause elevations in AST and ALT, especially in the acute phase, but not as high as the levels in this patient. Okay, so when you see super high liver enzymes, think about paracetamol overdose. Alcoholism usually occurs as usually causes a greater elevation of AST than ALT. AST, S stands for sake, so you can remember alcoholism causes higher AST compared to ALT. Chronic alcoholism is also usually associated with reduced albumin and protein levels due to reduced hepatic synthetic function. Abdominal ultrasound is especially useful for imaging of the biliary tract for gallstones, signs of obstruction, and cholecystitis. In this patient, these diagnoses are much less likely than paracetamol overdose, given how high the transaminitis is. Okay. Next question. Which one of the following statements regarding Perthes disease is incorrect? What is Perthes disease again? I think it's more common in boys. 10% bilateral is sounds like something familiar. Due to avascular necrosis of the femoral head, probably. Complications include premature fusion of the growth plates. I think so. Typically affects children between the ages of 4 to 8 years. That sounds about right. But it's supposed to be more common in boys. Yes, Perthes disease. Perthes disease is a degenerative condition affecting the hip joints of children, typically between the ages of 4 to 8 years. It is due to avascular necrosis of the femoral head, specifically the femoral epiphysis. Where is the femoral epiphysis? So this is the epiphysis, is it? No, the head is the epiphysis. Femoral head is the epiphysis. Impaired blood supply to the femoral head causes bone infarction, but this disease is 5 times more common in boys. Around 10% of cases are bilateral. Features: hip pain develops progressively over a few weeks. Limp, stiffness and reduced range of hip movement. X-ray, early changes include widening of joint space. Later changes include decreased femoral head size or flattening. Diagnosis: plain X-ray, technetium bone scan. Complications: osteoarthritis, premature fusion of the growth plates. This is an X-ray of Perthes disease. You don't see the epiphysis anymore. It's like flattened. Extensive destruction. Management. Keep the femoral head within acetabulum. Less than 6 years observation. Okay. So it's due to avascular necrosis.
On our YouTube channel, you'll find a limited 7 growing collection. Childhood hip disorder that occurs when the blood supply to the head of the femur gets disrupted and leads to death or necrosis of the tissue. The disease was named after 3 doctors, Arthur Legge, Jacques Calvet, and Georg Perthes. The hip joint is a ball and socket type because the ball-shaped head of the femur sits and rotates inside the cup-shaped socket called the acetabulum. This gives the hip joint the ability to move nearly in all directions, as long as the ball can smoothly rotate inside the socket. Now, the head of the femur is supplied by branches of 3 arteries, the medial and lateral femoral circumflex arteries, as well as the artery of ligamentum teres. The arteries send branches that climb up the neck of the femur to supply the head of the femur, providing the tissue with the nutrition it needs to grow and maintain its spherical shape. In Legge-Calvé-Perthes disease, for some children, the blood supply to the femoral head becomes interrupted for some reason, and it's not known why exactly. The result is that the tissue begins to die off, a process called avascular necrosis. Over time, there's new blood vessel formation into the necrotized bone that allows the dead tissue to get removed by immune cells called macrophages. That process causes the head of the femur to lose mass, leaving it weak and prone to fractures. When this happens, the head of the femur becomes misshapen and can no longer smoothly rotate inside the concave acetabulum, which results in reduced range of motion. Now, over time, Legge-Calvé-Perthes disease typically self-resolves, and the bone is able to heal. Once again, it's not exactly known why or how this happens. When bone remodeling occurs, new bone replaces the necrosed bone, and the spherical shape of the head of the femur gets restored and properly fits in the acetabulum again. With time, there's normal functioning of the joint once more. Children with Legge-Calvé-Perthes disease develop a limp and hip pain, which is sometimes referred to the knee. The pain usually gets worse with activity, which may even make the affected hip very difficult to move. This particularly affects abduction, moving the leg laterally away from the body, as well as internal rotation, which is turning your leg inward. Also, because the affected leg is less used, its muscles may become atrophied, causing the leg to look smaller than the normal one. Diagnosis of Legge-Calvé-Perthes disease mainly involves taking x-rays of the hip, which reveal a flattened and misshapen femoral head. In addition, an MRI can be done to see the shape of the bone, as well as look for the formation of new blood vessels. Legge-Calvé-Perthes disease can sometimes resolve by itself over time, so treatment is mainly conservative, involving rest, pain management, and physical therapy to preserve joint mobility. If the head of the femur is very fractured, surgery may be needed to affix braces and abduct the head of the femur to maintain its spherical shape as it regenerates. Alright, as a quick recap. Legge-Calvé-Perthes disease refers to a childhood hip disorder which occurs when the blood supply to the head of the femur is disrupted for unknown reasons, resulting in avascular necrosis of the head of the femur. Children have hip limping and pain which worsens with activity, and it may be referred to the knee. The diagnosis of this disease is mainly done with x-rays and MRI of the limping hip. Its treatment consists of resting the sick hip, having some physical therapy, and managing the pain, but also, hip surgery may be indicated. Learn medical knowledge more efficiently with osmosis.
Next question. A 23-year-old woman presents with lethargy. The following blood results are obtained. HB is low. Platelet is normal. White cells normal. MCV is low, so it's microcytic anemia. HbA2. What's HbA2? Hemoglobin A2 is high. What does that mean? What is the most likely diagnosis? Microcytic anemia, 23 years old. HbA2. Hemoglobin A2 is high. Is it beta thalassemia? Is it major or a trait? MCV is so low. I am tempted to guess major. Let's see what's the answer. The answer is trait. Disproportionate microcytic anemia, think beta thalassemia trait. A microcytic anemia in a female should raise the possibility of either GI blood loss or menorrhagia. However, there is no history to suggest this, and the microcytosis is disproportionately low for the hemoglobin level. This, combined with a raised HbA2, points to a diagnosis of beta thalassemia trait. The thalassemias are a group of genetic disorders characterized by a reduced production rate of either alpha or beta chains. Beta thalassemia trait is an autosomal recessive condition characterized by a mild hypochromic microcytic anemia. It is usually asymptomatic. Features: mild hypochromic microcytic anemia. Microcytosis is characteristic, disproportionate to the anemia. HbA2 is raised. Beta thalassemia by osmosis. Goody.
Beta thalassemia is a genetic disorder where there's a deficiency in production of the beta globin chains of hemoglobin, which are the oxygen-carrying proteins in red blood cells, or RBCs for short. Beta thalassemia is most commonly seen in Mediterranean, African, and Southeast Asian populations. Normally, hemoglobin is made up of 4 globin chains, each bound to a heme group. There are 4 major globin chain types: alpha, beta, gamma, and delta. These 4 globin chains combine in different ways to give rise to the different kinds of hemoglobin. First, there's hemoglobin F, or HbF, where F stands for fetal hemoglobin, and that's made up of 2 alpha globin and 2 gamma globin chains. Hemoglobin A, or HbA, the major adult hemoglobin form, is made up of 2 alpha globin and 2 beta globin chains. Finally, hemoglobin A2, or HbA2, accounts for a small fraction of adult hemoglobin in the blood, and it's made up of 2 alpha globin and 2 delta globin chains. With beta thalassemia, there's either a partial or complete beta globin chain deficiency due to a point mutation, which is when a single nucleotide in DNA is replaced by another nucleotide in the beta globin gene present on chromosome 11. And most often, these mutations occur in 2 regions of the gene called promoter sequences and splice sites, which affects the way the mRNA is read. The result is either reduced or completely absent beta globin chain synthesis.
Okay, gotta go. Bye.